Find you.
All right, Lyle, I'm going to start admitting people into the room. If you want to count back in your head backwards from 10, and then when you get to 1, you can start speaking, okay?
All right, very good.
Thank you.
This meeting is being recorded.
Well, good morning and welcome to session 5 of the Iowa Ideas Conference. I'm your moderator for this session, Lyle Muller. This session, Preventative Care, is within the track Healthcare. And in the session, we're going to talk with the panelists and address audience questions. All of our sessions have closed captioning access, and all of our sessions are being recorded. Before we start, the whole team here at Iowa Ideas would like to thank the conference sponsor, ITC Midwest, which has a quick message for us. Or not quick. Well, let me just say this and then we'll move on. That having that sponsorship from ITC Midwest is really crucial for Iowa Ideas. It makes it possible for people to attend this conference without any cost to them. And it allows us to put on a really good session where we can generate discussion, generate ideas, identify problems, and try to find some solutions. So we're very thankful for ITC Midwest support. Our panelists today are Dr. Dustin Arnold, who is the Chief Medical Officer for Unity Point Health at St. Luke's Hospital in Cedar Rapids, Dr. Tony Myers, Vice President of System Quality Risk and Medical Affairs at Mercy Medical Center in Cedar Rapids, and Kyle Ray, a principal and an advisor in the self-funded practice at True North Insurance and Financial Strategies, also in Cedar Rapids. Gentlemen, welcome. I want to start by each of you just taking a turn elaborating on what you do in a brief, as briefly as you can, and also how it connects with our topic today. And we'll start with you, Dustin.
Well, good morning. I'm Dustin Arnold. I'm the Chief Medical Officer here at St. Luke's Hospital. I was born here, so my relationship started quite a long time ago. In the capacity of Chief Medical Officer, I help act as liaison between the medical community and the medical staff with hospital leadership, and preventative health care and screening measures fall under my purview. And I look forward to today's conversation.
Kyle?
Good morning. I'm Kyle Ray. I'm originally from Georgia, but I've lived here in Iowa for the last 10 years. I've been working at True North and the self-funded employer healthcare space, working with providers as well as working with employers, trying to find ways to be able to get more of their employees engaged in their own healthcare in the way of preventative to reduce overall risk for employers. Glad to be on here.
And Tony?
Yeah, similar to Dustin. So we have similar roles. Although I will say that when I first started, I'm the Chief Medical Officer now at Mercy, but when I first started, my focus really was on quality, and it was a lot of it had to do with payer contracting, value-based payer contracting, and which preventive care is kind of one of the most critical parts of that. And so that's kind of how I started.
Thank you. You know, we're past the COVID pandemic declaration, at least, but the virus still is with us at this time. And you, Dr. Arnold, have said we're at a crossroads in preventative care. Could you start us off by explaining what you mean by that?
Well, I think Yeah, we are at a crossroads in preventative care. We in healthcare, some people have described the system as broken, and it's not broken. It's just the wrong system, and it incentivizes things that don't correlate with preventative healthcare. It incentivizes novelty, innovation, efficiency, and profit. And we're at a crossroads where we have to decide that we can continue down that path, or we can start to make an investment in preventative care, actually using the vast resources and innovation that we are known for more for health than treatment of illness.
Costs become an issue for that, do they not?
Cost definitely an issue.
And how do we put that into perspective? Kyle, you deal with cost when you're dealing with self-insured companies. How do we deal with cost?
Well, it's the Pareto principle through and through that 20% or fewer of the actual participants on a plan generate 80% of the cost on a health plan. When you look at just across the national statistics, we spend twice as much as most industrialized higher income countries, yet we still have 2 times the obesity, diabetes, and other comorbidity factors. And on the health plans today, we still have a higher usage of preventative than what you would see from uninsured or publicly insured types, because employers are incentivizing people to get preventive exams, but it's still incredibly low. You still have probably 35 to 40% of people on the health plan are actually getting these preventative services. So it's just across the board, the lack of proactive or preventative medicine in our group is just, it's resulting in incredible cost across the board.
Dr. Myers, how can a hospital facility like Mercy Medical Center try to promote this idea of doing preventative care checkups and whatnot?
Yeah, I mean, it's really interesting to see how this has changed over the years. And I'm a primary care physician, so I certainly understand the history behind it, that it was driven primarily through the doctor. And one thing, and I'm sure Dustin will agree with me, is that if we're trying to drive things through the doctor primarily alone, that's not going to be very effective. And there are many reasons for that. But so one of the things that we have gone from, helping the doctor and reminding the doctor and their staff that somebody needs something, to actually just, even as a system, going directly to the patient. So we do have a relationship, and we got to capitalize on that relationship. With my patients, I still practice. So we have letters that are generated that go out. In fact, I just signed off on some for various screening, whether it's lung cancer screening or colonoscopy or mammograms, that are going to go out under my name, with a letter under my name, but the system is generating it. The system will also be responsible for sort of reaching out to them again and scheduling it and things like that. So it's taking it off of me and off of my staff, and all I need to do is review the list and say, yep, all of those people are appropriate for this screening, and then the system takes care of it. And that's a significant difference compared to even 10 years ago.
Well, let's go around.
And it's very effective.
Sorry to interrupt. Let's go around the horn before we get into some of the meat here, and just state briefly about the advantages of regular health checkups, family life decisions, any other kind of methods of preventative care.
Well, you dig the well before you're thirsty. And so in doing preventative care, you can, for example, screening colonoscopies. We've seen just a recent study, this is prior to the pandemic, so I would lose sleep over if I thought if it was going to include the pandemic, but it showed that cancers are more aggressive and they're presenting at a younger age. And you've seen some of the screening measures drop down. Colonoscopy now is 45, 10 years, the index case in a family pedigree. But the ability to prevent illness or to catch illness early in the phase leads to more success in returning that patient to a healthy lifestyle and participating in society. And Dr. Myers is right that we have advanced somewhat, getting away from volume and going more towards value and using technology to contact our patients. But I think you need to understand in healthcare is different from other industries. You have what's called the big three in security: a name, a birth date, and then some sort of number, medical record number, et cetera. And all three of those have to match. And they don't necessarily always match. So we at times we're kind of limited in the degree of technology we can use, where other industries might just have name and be able to send information, et cetera. So it's changed a lot in the last 10 years, but we have a long way to go till we catch up with other industries.
I would just throw in too, real quick, that the cost part of it is really clear, and you can look at, so often when they try to do cost analysis, which are very, very complex, but there are experts that do this all the time and more to say, what's the benefit to this? What's the value? And so often we use like a year of life gained from some kind of intervention. And so if you look at, and they call it quality adjusted life years, but if you look at something like colonoscopy, depending on the screening method you use, it's costing between $7,000 and maybe $30,000 per year of life gained. And if you compare that to a lot of the interventions, this goes back to what Dustin was saying about how much money we spend when people get sick. Even if you do something that's totally indicated and appropriate, like a coronary artery bypass graft, an open heart surgery on somebody that's relatively young in their 60s, relatively healthy otherwise, the cost per year of life gained is more in the close to $100,000, and that's in somebody that's that. And so we do those procedures all the time, and it's very acceptable and expected in our culture that we're going to spend that much money for that kind of gain. And I'm not. Those are decisions that I don't even think about as a doctor. But to sort of be very willing to spend that much money, and people very willing to go in and have open heart bypass, but unwilling to come in and get something that we know is going to have much more benefit or much cheaper and get much more long-term benefit out of it. That's what's disheartening to this. And that's why we need to do better, clearly, with preventive care.
And I see it very often on health plans, the unmanaged diabetic states, people going in and having a foot amputated, whereas the managed diabetics are much more cost efficient, less ER visits, less resulting in the amputation. And as the doctors have said, I'll leave the medical opinions to them on this, but it's suggested by the National Institute of Health that just obesity alone on health plans is $8,000 more. And I would supplement that with, it's not just the obesity, it's the obesity with other comorbidity factors that are unmanaged and untreated yield these types of outcomes. And so the cost is absolutely rising. In the Midwest, it's the life decrease for 35 to 55-year-old males. It's because of these comorbidity factors is incredibly costly.
But Kyle, part of it is that there's no transparency in the pricing. So it's not like you can say, well, okay, here's my coupon, I'm gonna get my open heart done a little bit cheaper, or I've done all this other stuff and now I had my punch card clipped and I get a free whatever, but there's just no transparency. And that's where the system is the wrong system.
And why is that? I can recall a few years ago when the Cedar Rapids Gazette did a story in which we tried to call different healthcare providers and ask them, what are the prices of these procedures? Because we're told we're supposed to shop for better pricing. So what is the hang up there? What's going on? Because when we talked to some of the healthcare providers, they themselves didn't know.
Oh,
they couldn't tell us.
We have, I don't know for sure, but I'm gonna guess. And Kyle, you probably can answer this question. How many payers do we have in Iowa?
Really, you have two or three main payers.
But you have a lot of smaller ones.
Yeah.
And who are those main payers?
You have Blue Cross Blue Shield, you have United Healthcare would be your two largest, and 66% of Iowans are covered by an insurance carrier versus a Medicare, Medicaid, or uninsured.
Okay, and go ahead, Dustin.
So you have these different payers that have different rates that they reimburse. And so you get to this point where if you're a business and you're not charging what the highest payer pays, then you're leaving money on the table for your business. And that just complicates the system. And so it dramatically punishes the uninsured or underinsured. And so that leads to this complex system of pricing that is just it's not based in reality. And then, not to bash in the insurance industry, Kyle, but there's an incentive for it to be expensive, because if it wasn't, then you wouldn't buy insurance. You would just, if you knew that it was going to cost X amount of dollars, you just go get it done, right? But you don't know. You go to the ER, you do not know what your price is going to be. You do not know what the bill is going to be. And part of that is the widgets in this particular industry are human beings, and we're all different. And we have different stories and risk and benefits, and so that complicates the system as well. But Lyle, you're absolutely right. I don't know what it costs to see a doctor.
I agree with you on that. To me, the billing system is only set up to be able to pay providers to treat problematic symptoms right now. Obesity is not a reimbursable code for insurance carriers. It's considered cosmetic. But if there's one thing that could drastically reduce the overall risk as well as cost structure, is to be able to help people to live a healthier lifestyle, to be able to deal with obesity. I think it would also assist with the mental health aspects of things. You feel better, across the board. But that's not something a provider gets reimbursed for today. So a lot of times it is not even in the billed amount. It doesn't even show obesity when I look at the data on what's coming through. So to me, it's trying to get to a system to where we can pay providers to have healthier, happier individuals versus what scan did you run? What extra tests did you do? That to me is, and that's what, we've talked about it before, but that's where the dental industry went many years back. And now that's the way of life in the dental industry, is preventative, not how many root canals can I do today?
And then, Dr. Myers, how can we make preventative health care for a regular health as natural as it seems to be to go to a couple of dental appointments in a year?
Yeah, having a strong primary care network is critical. And there are lots of places. Actually, we're in relatively good place in Iowa. There are a lot of places that don't have that kind of strength. And it's, when I think about my patients, I see them every year. But I've been in practice for a long time, and the ones that don't want to see me every year have migrated away from me. And so there is a difference. I don't see it in my practice really at all, as far as people that aren't coming in. So that relationship and having that strength of primary care bench is really critical. I also just want to touch really quickly on some of the stuff because this is, in many ways, it becomes rapidly a public health discussion. And because we're looking at obesity, which is a public health problem, and then it sort of morphs into, it's like, well, why is this? Is it, it's healthy food access, it's access to outdoor stuff. So when as a physician, and I've been doing this for a long time, about 30 years, all of the things that I can do in the office often are not that much. I can certainly do some guidance on healthy diet and all that kind of stuff. But if you look at the major impact, and this is, we're not going to get the answer to this, but there are a lot of public health issues that would help address this if we could focus more on the things that I'm talking about, healthy diet, access to healthy food, access to outdoor activities, those kinds of things, and transportation and all that kind of stuff are really going to be impactful. And poverty is linked to all of this stuff as well. And if we just pulled out probably one, and I don't know, I'm sure you've probably done this, Kyle, is just look at poverty. If we did that, and we're not going to fix that here this morning, but if we fixed that, a lot of this cost problem would go away.
Well, I do think though, Tony, in the last 5 years, just prior to it, we started to address, at least identify socioeconomic issues in our patients. I mean, when I was in medical school, they didn't tell me to ask about that. I mean, some of it's common sense. The patient that can't afford their medicines is not going to take their medicine. And so I do think we've made a step in the right direction to at least have that discussion with patients, which I think is a good thing, because not all patients are the same. I mean, this is tongue in cheek but a little sarcastic. People that live on Country Club Drive don't get readmitted to the hospital, because they have a social network and social economic status that helps them. Other people that don't have that support system, I mean, we are their support system, and that's not what we're set up for. And so I think the fact that we're talking about that makes me feel slightly optimistic, cautiously optimistic.
I agree that the numbers don't lie in that regard. The income disparity is absolutely a main variable that is strongly correlated to the use of preventative services and just overall cost. And the other piece and I don't know this and would want to ask you to, is that with the rising mental health and mental health concerns with, I would say, 18 to 30-year-olds as well as dependents, my feeling is that it's hard to think about your healthcare in a proactive way when you're worried about paying the bills, when you have other mental health issues that just naturally take your attention away from being concerned about being proactive. To me, we get distracted by what is the most urgent thing right now. And I think that with mental health, the rising cost in that area, the rising needs in that area is also another barrier, as well as income disparity.
Yeah, I think patients that are in survival mode for the day, they cannot think about preventative health care. It's that simple.
One of the solutions for people who don't have adequate health care and adequate incentives for preventative care is through insurance, employee provided insurance. But what about the people who don't have jobs that don't provide, or don't have jobs that provide insurance as part of the benefit package?
I think there has to be some, and I'm sure there's going to be, Dustin's pushing for socialized medicine, but there has to be some sort of government solution. But Lyle, you might know off the top of your head, what are we, healthcare, 20% of GDP, 18%, something like that? I mean, at some point,
yeah,
our government needs to step in and say, this is a significant proportion of the GDP. It's now our problem.
Growing.
Yeah. So there has to be a government solution. I don't think you can keep putting this burden on employers, and then you have too many people that fall through because they don't have either the people that suffer the most, and Tony will agree with me on this because we've dealt with it our whole careers, is that working lower middle class. Mm-hmm. They're too rich for public assistance, and the jobs they have don't provide benefits or solid benefits. And that is a significant burden on the health care system.
I would agree, because the numbers are so different for people on an employer-based health plan. It's, like I said, closer to 40, 50% actually get preventative service. but overall Americans, it's 8%. So when you look at the numbers, the employers doing the incentives with voluntary wellness programs, incentive or penalty, however you want to look at it, gets more people engaged in preventive health. But to your point is the employers that are not of size or the ability to provide benefits, even though, you know, there's an individual marketplace where people could go and qualify for subsidies, it's still not a priority for these people, or there's something else going on that they're trying to get food on the table. And so I don't know if, as you mentioned, I do think at some point in time that we're going to have to look at the government stepping in more than they did with just the ACA to address preventative types of measures. I don't know if it's mailing people the kit to do the biometric screening at home and doing a teledoc type of consult on that, just so they know their numbers, they know their risk. But we're going to have to meet them where they are. If there's no ability to incentivize them through a premium differential like we do on the employer side, getting these people to think about, you know, their health proactively, there's no way to incentivize them. We are at least going to have to make it easy for them to get the basic numbers to know where they're at.
Al, do you know if data exists that show improvement in health in people who are insured through their employer versus people who don't have insurance?
I don't know off the top of my head, Lyle.
And Dustin or Tim, am I hitting you with a question on the spot there that we don't know the answer to at this point?
Well, you always want to be wary of the tyranny of anecdote, but I would say anecdotally, that's pretty clear. If you have good insurance, you're getting screenings done, you're participating in healthcare, you're having touch points with your physician in the clinic, and you're living longer. And don't smoke. You know, that's the other thing we're not talking about is please don't smoke.
We have internal data, and I'm sure that number's out there. I can't tell you, but we looked at this various disease entities, the common ones, you know, with diabetes, et cetera. And one of the biggest predictors of even having the disease, this goes back to your preventive health argument, is whether you're insured or not. And so if you're insured internally based on our data, and I don't have it in front of me, is that if you're uninsured, you are much more likely to have diabetes. And so I'm sure those numbers are out there. We just did that internally because we were looking to links for all these social things. And how linked was it to transportation? How linked was it to, you know, food deserts? All of those kind of things have impact. Strongest one was whether you have insurance or not, on whether you got diabetes.
But Tony, that could also be a marker of other socioeconomic benefits too.
Yeah, absolutely.
Right. You know,
yeah, it's going to be linked to poverty. Clearly, it's going to be linked to that.
Right.
So yeah, they all kind of go together. But that was something that we could, as an institution, you talked about things that we tried, is that when we do have somebody come in that's uninsured or underinsured, we used to work like crazy to try and get them insurance while they were in the hospital, but we didn't spend a lot of effort after they left. And so because of when we were looking at this data, we said, well, you know, we should continue, even though that's a cost to us with no reimbursement, to try and help these people continue down the line to get some type of insurance. And whether they qualify for a federal program or a state program or some kind of assistance, to follow that along, because often they get out of the hospital and, like we said before, they just go to the next problem, which is kind of my life, actually. I go from problem to problem. But if we can use that resource, because downstream it will help us as well, and it will not only help the patient. So we did commit to doing that, and that's one of our sort of social programs that we've committed to over the last year, is to staff up and pay people to follow up with patients once they leave the hospital to help them get insurance.
Is Iowa still struggling to get family doctors located in its communities?
Certainly in rural areas.
Yeah, rural areas. I think, you know, I don't think proportionally to other places, I think we're doing okay. And I'm basing that on the number of like visas for foreign graduate physicians we get allocated. That hasn't changed. So that indicates that we're probably steady in that standpoint.
And let's get to that rural Iowa. We're a rural state. I often think of an anecdote from my own experience in which I had a health episode in rural Montana, and the doctors out there gave me some kind of medicine that had crazy side effects and said, here's what you do to control this. And I told my doctor back in Iowa City this, and she said, don't do that. The side effects are terrible. You live in the Iowa City, Cedar Rapids area, just go to the hospital. We have plenty of good hospitals in this area. But there are other parts of Iowa that don't have that advantage. And I'm wondering about, we're going to start with telehealth, and because that's kind of the solution that we toss about. And I'm wondering if you could analyze a little bit about telehealth and some of the advantages of it and some of the things that you think still need to be done to make that effective. Tony, why don't you start?
Well, pandemic obviously, sped us along the timeline of telehealth, although we were very lucky because we'd already had it in place. It was just not being utilized very much. And then the pandemic, and then utilization went way up. There's certainly, and everybody knows this, there's certain specialties where telehealth is clearly the way to go, right? I mean, behavioral health, mental health stuff, it's clearly so important. But obviously that has and I like the idea that Kyle was saying about you just send stuff and get stuff back. At least you get some objective information back, and then you can have them go to their drugstore and get their blood pressure taken or something like that. There are ways to use telehealth, I think, to improve that kind of primary care or primary screening for preventive health. But I think at this point, we were really, during the pandemic, payers were encouraging us to do it this way. And so it goes back to the payer structure at this point, because we would be very happy to work harder on that if the pay structure reflected how important it is. And at this point, a lot of the payers are going back to that it's not that important.
What I've seen for employer plans is that the typical kind of telehealth structure where it's kind of like a doc in a box, and it's just a national setup where they're licensed to do it in the state of Iowa. And so if somebody calls, they can treat certain things. It fell off very quickly when they said, well, I can't handle that, so you'll need to go in. People stopped using it after that. What we have found that works is when the local providers have the structure set up where there can be a continuity of care into the urgent care, into their doctor's office, but it's a great first step in a lot of cases. But we have seen employers also doing more of those direct to local provider type of virtual care setups where they can incentivize their people, $0 cost, to utilize this as a first stepping point. Before the pandemic, there was very low utilization of any telehealth, as mentioned. During the pandemic, it picked up. Shortly after the pandemic slowed down or ended, it went right back down to where probably 2% of an employer plan will actually use telehealth for anything. But employers, I hear it all the time, employers are trying to find solutions to go direct to basically local providers to be able to get these services done, as well as I mentioned, those kits that have, the different, you take your biometric screenings, whatever, then you have the consult with a provider doing anything they can. But that to me is only handling the insured side of things. There's still the uninsured or underinsured side of things, or employers that aren't doing this. And that to me is, again, where there needs to be more of this public support to be able to get that for everyone.
How has telehealth changed the way we deliver healthcare, or has it, or is it changing much right now, Dustin?
I think it's allowing particularly psychiatric services, mental health, to be utilized in rural settings, and perhaps subspecialty care. Neurology comes to mind. That's being done. I'm kind of still old school, and I know I'm in the smaller minority, or growing minority, or shrinking minority. That yeah, you got to touch your patient. You got to see your patient, and you got to touch them, and there's nothing that replaces that. But I do think in the rural setting, Lyle, that telehealth has helped with mental illness, because there was a significant deficit in delay in care, and I think that's improved. It's improved. How much, I can't tell you what fact.
There are sections of Northwest Iowa, though, that still are quite the deserts when it comes to having adequate mental health care providers because of recruiting people to a small town or whatever that might be, or just the patient load. So where are we on that? You say, Dustin, that we're getting better. Is there room for improvement, and if so, where and how?
I think I can't remember. We had at the VA system in the early 90s. It was at ICN, Iowa Cable Network.
Yeah. Yes.
Is that right?
Yes, it was. Yes.
And I don't know that kind of fell off, but that was starting and making some progress to get some of these services out to the rural setting. One-on-one discussions with physicians at the university, they'd be more than happy to provide that service. It's just the infrastructure to get it, and I'm 54, and I remember in the 80s, Northwest Iowa didn't have 911 service. You had to dial a 6-7 digit phone number to call the fire department. So I don't, we don't think of Iowa as a desolate state, but there's challenges in the rural setting to providing healthcare.
How are insurance companies handling telehealth now?
So insurance companies will actually provide for free or very low cost alongside of their products, their insurance policy, a telehealth solution. But it's still very, very underutilized. And again, I think Dustin made a point about this, that that relationship with a local provider is absolutely necessary, in my opinion. Everyone that is a high risk walking around, they know they're high risk. They know they're smoking. They know that they're probably morbidly obese. And having a relationship with a trusted advisor who can tell you that is so much different than someone just quickly reviewing results and telling you something you already know. To me, the relationship aspect with a trusted provider is key to getting people to actually have behavioral change. And so I think that although the telehealth is great for rural areas, it's great for a lot of common types of issues that can be just cheaper to handle. It is to me, it needs to be a pathway into a local provider with a relationship. The national kind of setups, you feel, and this is what I hear from employees that have tried it, you kind of feel like you're in the assembly line. It's not a relationship. So to me, it's innovation that is absolutely necessary to explore more and to not let just kind of die on the vine, but we need to tie it back to what we know needs to work, which is that relationship with a provider.
As we're talking about rural Iowa and telehealth, and I hear what you're saying about that personal relationship. But again, if you have to travel an hour and a half for that's a good chunk of a day for somebody.
Oh, I practiced in Grinnell for 6 years, 5.5. And to tell someone they had to drive to Des Moines for a service, I might as well said, you need to take the Concorde to Paris, France, because it was just as insurmountable for them because they haven't left their county or their section of the county and their small town. So you're absolutely right. The distance is an issue, and sometimes these solutions don't take geography in account. It's easy to be in the Beltway, New York City, a densely populated area, and have a simple solution, but it is a challenge in rural healthcare.
I think with telehealth, though, if just kind of sticking to that, though, the difference in being, 90 miles away, but always talking to, say, Dustin. If Dustin's my local provider or my provider on a telehealth structure, always talking with him where you still develop a relationship, you're talking to the same person. And also your information is going into the electronic health record system, which doesn't always happen in a telehealth type of structure. To me, I think there's still a blending or a hybrid approach where, yes, we may be doing it telehealth or televisit more often, but at least there's that familiar face and a trusted advisor that I have on the other end that knows me. I think that relationship can still happen on a telehealth infrastructure for rural places.
But as we get into the rural areas, we also have an internet broadband issue. Wisconsin Watch, a nonprofit news organization, just this week reported about all of these areas in rural Wisconsin that don't have access to internet. We've talked about it in Iowa, and it's not a problem that's related just to Iowa, but a lot of states that have rural areas. The easy answer to the question of how do we deal with this is get high-speed internet to rural areas. But is that just the answer, or are there other things such as awareness that we need to be thinking about here in the state of Iowa? Tim, do you have some thoughts on that?
Tony, that's all right. My brother's Tim, so.
Oh, Tony. Yes, I'm so sorry. Yes.
And we got a lot of Tims around here. Yeah, I mean, I think, having a broadband set up critical, obviously, for many things. I think, federally and at the state level, we are investing in that, and there's money there. So, but the health systems need to also develop that kind of structure to support it. And even if, so even if, say, Unity Point or Mercy, we don't have enough providers to take care of the rural people in Iowa, as far as primary care goes, for sure. So you would have to have some kind of development of structure. And again, that's always kind of a, if we have a batch of funding and then we're getting the broadband, so that's great. They're not going to build the broadband before they get the money, right? So in healthcare, we're kind of in a tough position often where we're trying to spend our resources, and resources are getting tighter and tighter in healthcare to get ready to do something to support, say, broadband telehealth access in Iowa from a primary care standpoint. But we don't have nobody's giving us any money to develop that structure. So there's going to be some type of delay. And the way that it works historically is there'll be sort of an opportunity, and hopefully it doesn't get lost. But then, we have to wait and get help from the payers to sort of develop something like that, so that then we can sort of support that service. Because, it'd be great to do that. And it'd be great to have sort of local, and we're close enough to a lot of Iowa where they needed or wanted to come and see us, maybe, once a year or something like that they could, or once every 2 years, or once every 3 years. I do think that coming from the local, keeping it within the state of Iowa is the long-term answer. But how do we build that structure, and how do we support that structure? It's still a question.
Well, and I also think, to get in the weeds a little bit, I think the tort reform last year will help keep particularly obstetrics in rural communities. You can't deliver a baby over telehealth.
Yeah. Well, and actually, I want to talk a little bit about child health care, not necessarily OBGYN deserts that are developing in Iowa, but Healthy People 2023 said an increased proportion of children need to get care, that there is a need to increase the oral health system and to get adolescents to talk privately with doctors. That's where you start these habits, right? In young age. How do you try to reach these families, especially for young people, children, adolescents? Where are we in Iowa, and how are we doing? Dustin?
Well, I had two teenagers in the house at one time, so I don't know if I'm an expert at talking to teenagers, that's for sure. But we're blessed in Iowa that we have a wonderful children's hospital at the University of Iowa, and we're kind of spoiled from that standpoint. We get really good care, subspecialty care for our children, and we should be very proud of that. But there is a disconnect. I mean, you're right. It starts in the home. These discussions about healthy eating, good sleeping habits, and I don't really have a good solution for that other than wife and I are empty nesters, and so I think we successfully achieved that. But that's probably about the end of my expertise when it comes to talking to adolescents.
Tony, you run into them, and then Kyle, I'll get to you too. Sorry to interrupt.
Yeah, I mean, a lot of this, it has to do with the long-term relationship really with the family. And it's not just about the adolescent, especially if you're talking about healthy behaviors and things like that. So if you have a long-term relationship with the parents, and then, you teach them and they teach their child, you do run into kids, especially in the range of 10 to 14 or 13, before they go through their major sort of selfness, is that they will sort of go all over their parents, right? I mean, it's like smoking. It's classic. I talked to a child about smoking and they just work on their parents like crazy that are smoking. So it works both ways. I think we do support kids' health in Iowa and across the country pretty well. There are backstops for children and having insurance when poverty is an issue, so they can at least get preventive immunizations and those visits and nutritional support. It's always a fight, right, to maintain that support, but we're doing a better job in children than we are across the rest of the population. I think it's something we can't lose sight of, because anytime that there's some kind of social support program, it seems to be under fire all the time. But it goes back to the original thing that I'm talking about, with if you see kids that are in not necessarily trouble, but they're at risk, that it's just so related to poverty and backstopping that. And it becomes more of a public health issue than it does a doctor issue.
Yeah, I think you just said it all on that. When you look at where a lot of the problem in that area would come from, you could go with a certain amount of high correlation between income disparity. What we know isn't going to solve it is just having educational pieces in our high schools about eating healthy, about not smoking. It's just not going to do it. It takes leadership in the home in order to be able to get your children to do anything. So to me, we require kids to have immunizations before they go to school. I wish that we could get to a point where we took more of a preventative mechanism for all family members, that you have to get certain things done, pre-employment, whatever the case may be. There needs to be some type of public support or intervention to get these things done for all Iowans, not just for the kids to be able to go to school. That when I look at the burden on employers today having to pay for healthcare, but having no real stick, if you will, to be able to make sure that people are getting their oil changed before their engine blows up. It's a pretty rough crisis that employers are facing to be able to foot the bill. So no different than kids going to school. I wish we could get to a point to where we thought of it being something that's essential preventative care for kids and adults, and not just hoping they get it done.
One of
We
the
get,
people
we
that-
get tax write-offs for, we get tax write-offs for using solar or installing solar panels or a cheaper refrigerator. Why don't we get tax benefits for getting preventive health care?
I actually, and I'm always a little wary about too much of that, but I agree with you 100% that if we already are going to foot the bill, that's going to be 3 times higher when it's not taken care of early. The ACA, people ask me occasionally about the ACA, and I always say it either went too far or it didn't go far enough, because you can't just put the burden on someone else to pay the bill. We have to also put the burden on the people that you have to get your oil changed. And if you don't, what we found in the employer healthcare insurance system is that you have to create incentives and penalties to be able to get it done. And to me, that is a prudent step if you're going to have someone else paying for it, is to make sure that they at least do the basic parts.
How seriously is a message of, say, tax breaks for wellness checks being pursued with policymakers, or is that simply an idea that you would call aspirational instead of attainable?
Aspirational.
Yeah, I haven't heard of anybody having a discussion about that at a policy level.
Yeah, I just wanted to put that in perspective. One of the people who was attending this conference asked a question, wondering if it's possible that a family practitioner could have a combined appointment with a parent and a child, so that the parent gets a preventative appointment and the child gets a wellness check at the same time.
Oh, that's happening on some level with certain practices. They're seeing both.
Good. All right. And again, you get to that family lifestyle thing then, right? With a question like that. Again, with rural Iowa, just want to kind of one other thing that exists, and we'll have a panel later about elderly health care, but a lot of elderly people are out there in these rural communities. Are they being reached adequately? And what happens when they finally get to the hospital? Do you see instances where you really wish they would have gotten some preventative care ahead of time?
Well, I used to joke in Grinnell that if a farmer calls and it's raining, put him on at the end of the day, because the only reason he's calling is because he couldn't be outside. If a farmer calls and it's sunny out, send the ambulance, because they're actually going to come in. And so they're a stoic bunch, which makes it difficult for them to come in just for preventative care. They don't want to bother you if they don't feel sick. So that is a certain roadblock. I think the subspecialty services in the rural setting are limited. As Tony knows, and this could be a whole nother panel, the staffing and hospital inpatient capabilities in the rural settings are going down. We get transfers from all over Iowa, and prior to the pandemic, we did not get admissions from Western Iowa. So people are having to go a farther distance to be hospitalized, and that's concerning, because that will have a halo effect on the community over time.
One of the people who's attending this session has a question about this. Are there strategies that other countries use to address preventative care that we could incorporate it in the U.S.? And there's a comment in here that it seems the healthcare costs are higher in the United States, yet the outcomes don't reflect the price we pay in this country.
That's because the system's not geared to provide the best outcomes. It's geared to provide innovation and profit and volume. So what we do in the United States is the best healthcare in the world. We just do too much of it at times. So If we can put in a pacemaker in someone, well, we should put pacemakers in everyone that needs it. And that's not always the right answer. Innovation doesn't always benefit the general population. It's not designed to be innovations of health, but it's innovations of speed and efficiency and profit.
Kyle, your head there, and so is
Yeah.
Tony.
Yeah, I would just say that, I mean, most developed countries have some kind of a national healthcare system. So, things are paid for, even if it's driven through not-for-profit insurance companies or things like that, like in Germany. But pretty much everybody does have that. So we are somewhat alone in being a developed country and not having access to healthcare for everybody. And so, and the cost. There's kind of this artificial thing. There's no question. Dustin's right. We have the best healthcare system in the world. We can take care of the most complex problems and do it better than anybody else. Where we fail, which is directly related to the outcomes, is in preventive health and all of these behavior things and poverty. If you look at the cost that our country spends on healthcare, it's huge. And relative to social programs, if you add those two on top of each other, I saw this great graph once that looked at developed countries and how much you spend on a combination of healthcare and social programs. And essentially, if you look at that, we are not that far off on them together. So what we do is we tend to spend less relative on social programs and more on healthcare compared to other countries. And so that's where that cost differential sort of comes up. And I think it goes back to, we've already talked about this, some kind of a support network for everybody, and really trying to address the problems that are triggering a lot of the bad outcomes, which are related to poverty and all of the things that go along with that.
We have about 3.5 minutes left in our session. And what I'd like to do as we wrap it up is to ask each of you what the key takeaway you think people at this conference ought to have when they think about preventative care, the wellness checks, trying to get ahead of the curve on dealing with healthcare issues. And Tony, why don't you start?
Yeah, I mean, I would say from looking at all the numbers and everything like that, is one of the first things that they need to do, and we all need to do this, is try and figure out how they're going to get some kind of insurance for healthcare. And then once you cross that hurdle, and I have a son that's turning 26 right now, so he's going off my insurance. So it's actually kind of an interesting hurdle. I mean, he doesn't have a lot of money. So once you've done that, that would be something that's going to help you dramatically improve your overall health, because then you can access the health system. Other than that, it goes back to the things, all the preventive stuff that we should be doing at home anyway, which is, trying to eat healthy and trying to exercise, and all of those positive behaviors will help us. Because sometimes if we cannot access the healthcare because of the financial situations we're under, then it's even more important that we take care of ourselves.
Kyle, how about you? We're talking insurance here.
Well, the interesting part, I love what Tony and Dustin were saying. I think we have the best healthcare in the world. If you are going through a really bad situation, we have a lot of practice at it because we have a lot of bad situations going on. And it's because we don't spend enough time like the other countries on the preventative side. And we have bad lifestyle compared to most other countries. We smoke, drink, eat poorly, and are sedentary. But if the takeaway for the average individual listening here, it would be to know we have the best healthcare. We have a preventative problem and a lifestyle problem. To champion the support from the public domain, the policymakers, on trying to put more emphasis on the payer structure, rewarding providers and paying them what they need to be paid to take care of people proactively, and not just pay them the most we can when things go horribly wrong. And I think that it all has to be fixed. Money is the issue. Where do we spend our money? And until we can decide as a community, as a nation, that we want to put our money where our mouth is and put it more into the preventative areas for everyone, because everyone generates risk, then I think we're always going to be having these panels and nothing happens. We have to get more proactive with policymakers about putting money into the preventative side of things.
And Dustin, you got about 30 seconds.
To the young people, you may feel invincible at 19 and 20. I know I did, but you're not. Live a healthy lifestyle. Don't smoke. Good sleep hygiene, and take some accountability for that in addition to everything else. And nobody will regret being healthy later in life. There's a lot of people who regret being unhealthy.
Well, thank you, gentlemen. It's been an interesting conversation. And if people are interested in rural health, that's coming up next. I want to thank everybody for attending this session. A reminder, next up on the health track is rural health in Iowa at 9:40. And then I'll be back with session 7 on the needs of aging Iowans. And that'll be at 10:45. Thank you all for attending. Thank you to Dustin, Kyle, and Tony for being with us as well.
Thanks for having us.